dearest colleague from different parts on the Middle East region. We do have guest speakers, eminent from Kuwait and from Lebanon, from definitely from Saudi Arabia, and from Egypt, and from the MEM as well. And of course, we do have also our guest speaker, Prof. Ignacio Gilbezo from Spain. And then we'll end with our dearest colleague, Dr. Nafisa, and Prof. Marwan with the Light Symposium. Today it's a very exciting night. Our topic this night is about the adjuvant therapy and the resectable non-small cell lung cancer. And we'll start our talk with our session with case presentations. And we'll start the first one with Professor Dr. Muaz Al-Nasser. Dr. Al-Nasser, he is a medical oncology consultant and one of the eminent speakers and faculty in the GCC area and Middle East as well. He will share with us one of his cases. Dr. Muaz, the floor is yours.
Thank you, Dr. Mervat, for the kind introduction. It's my pleasure to meet you and my colleagues. And I have a short and straightforward case. I will share my screen now. Can you see my slides, Doctor?
Yes, we can see it clearly.
So I have a 58 years old female with no comorbidities. In July, she noticed to have shortness of breath, worth investigation, and by simple chest X-ray, there is left lung shadow, but this was advanced to have CT scan in the same month, and which clarify there is a left upper lobe mass about 4 to 4.5 centimeter with para-aortic lymph nodes measure about 1 centimeter in diameter. Later on, PET scan was performed, which confirmed the avidity of this lesion in the left upper lobe of SUV of 9.9, with no other significant uptake, including the mediastinal lymph node, to suggest metastasis. This is the CT scan in July 2023. Clearly, we can see there is isolated lung mass in the left upper lobe. Later on, we had chance to have CT-guided biopsy, and which confirmed lung adenocarcinoma, and other staging workup like MRI brain was unremarkable. The molecular test from this biopsy, this is the MRI. Clearly, there is no space-occupying lesion in the brain, and the NGS from the biopsy confirmed that there is AMLA-ALK fusion oncogene detected, and this was then later on we had chance to have a lobectomy in November 2023, and the pathology confirmed invasive acinar adenocarcinoma. The size of the tumor 3.8 by 2.3 by 2 centimeter. There is 3 out of 19 lymph nodes were positive in station 5 and station 6. Based on the ALINA trial, we subjected this patient to have an adjuvant alectinib, started in December 2023. And this is unlike the EGFR, this in the ALINA doesn't require to have an adjuvant chemotherapy than the TKI. So we started right away the alectinib full dose 600 BID. The patient had good tolerance to this dose, and we had follow-up CT scans. This is after 3 months of, after 1 month of using alectinib. Clearly, we can see there is no lesion in the chest or other metastatic areas. And this is the latest CT scan confirmed that there is no detected metastasis in the chest, and also there is no other site of metastasis. The patient is still on alectinib, hoping to complete 2 years of adjuvant treatment. And with that, I conclude my slides, and I will give the mic to Dr. Mirvat. Thank you.
Thank you, Dr. Maaz, for sharing your lessons. Very interesting. تفضلي دكتورة نفيسة. Go ahead.
Thank you, Dr. Maaz. Very interesting case. Thank you. It's my pleasure to introduce the next speaker. And before that, thank you, Dr. Mirvat and Prof. Khalid Ghattan for inviting me and having me as a part of this education activity. And we'll go ahead and introduce the second speaker. He is Prof. Houri from Lebanon. Prof. Houri is a senior medical oncologist, and he is assistant professor, School of Medicine, St. Joseph Hospital, Beirut. And he will present a case of showing the role of adjuvant immunotherapy in early stage non-small cell lung cancer. Dr. Houri, please.
Thank you very much. Thank you very much for inviting me. Thank you very much for this introduction. And thank you, Dr. Mahrouz, for organizing such big scientific activity with a huge impact. Thank you very much. So it's a case of early stage lung adenocarcinoma, diagnostics, therapeutic, and immunologic perspective. So it's a case of a female of 68 years old, married, smoker. She presented in February 2024 with a persistent non-resolving cough. In March 2024, a chest CT scan was done. We found a speculated irregular right upper lobe lesion, 22 times 13 millimeter, showing interval growth compared to a previous scan from January 24th, 15 times 12. The lesion was surrounded by reticulomuconodular infiltrates. The PET scan showed only this nodule without thoracic lymphadenopathy or distant metastasis. The brain MRI as extension workup was normal. So the patient had right upper lobectomy showing a tumor of 1.5 centimeter, acinar subtype in the majority, moderately to poorly differentiate. We had visceral pleural invasion, lymphovascular invasion. The margin were negative. The immunohistochemistry, TTF1 positive, CK7 positive, napsin A plus positive. And on the lymph node dissection, we have 3/15 paratracheal lymph nodes. So classification is T2A and 2M0, stage 3A disease. So we did the complementary evaluation by PD-L1 showing 70%, TPS more or equal to 50, EGFR mutation was not detected. The gene fusion that we are doing in a rapid test in our institution based on IDELA was negative for AL, CROSS, RED, etc. So in this patient, we started after having a 3A stage lung adenocarcinoma, resected, an adjuvant chemotherapy with 4 cycles of vinorelbine and cisplatin. For sure, based on Empower 010, it was one of the candidates to receive after the adjuvant chemotherapy, adjuvant atezolizumab for 1 year, and based on this trial versus best supportive care, we had an advantage of disease-free survival, and also we have very interesting results of overall survival with more than in PD-L1, more than 50%, we have an advantage of 17%. So the patients, a PET scan was done after the adjuvant chemotherapy, and we started, based on this trial, the adjuvant atezolizumab. Also in parallel, the NGS was started. knowing that it's not indicated probably in the early setting. However, we are doing it in our institution to evaluate based on a clinical trial to sequence all the early and advanced adenocarcinomas, and we found a BRAF V600E mutation. So this patient received 3 months of atezolizumab in the adjuvant setting. A PET scan of evaluation was done in October 2024, showed thoracic lymph node recurrence with newly intensely hypermetabolic subcarinal and right hilar adenopathies. So in this case, what would be your preferred therapeutic approach in this setting? You will change the immunotherapy and consider it as systemic disease with high PD-L1, go for pembrolizumab. You will go for anti-BRAF, anti-MEK combination based on the BRAF mutation that we had. You will go for platinum doublet chemotherapy plus concurrent thoracic radiotherapy followed by durvalumab, or you will go to docetaxel plus minus ramucirumab. So this is very interesting trial published in 2022 with 4 patients by Borghetti, showing the importance of chemoradiation therapy plus durvalumab for local regional relapse of resected non-small cell lung cancer. However, in this trial, all the patients did not receive immunotherapy since it was not indicated when we had the recruitment in this trial. So chemoradiation therapy followed by consolidation durvalumab for local regional relapse was maintained based on this study. And in fact, after discussion in our tumor board and having also an opinion from Gustave Roussy, since the son of the patient is also a doctor in Gustave Roussy, we had the chemoradiation therapy with pemetrexed and carboplatin for 2 cycles with radiation therapy. And post-chemorad, we had a partial metabolic response, and we started with durvalumab as maintenance. In April 2025, we had 1 brain mets, and in this case, since it was single brain met, we did the stereotactic radiosurgery, and we decided to continue the durvalumab. The patient till now is under this maintenance. And also, we have some data by Bruni published in 2023 when we have a stage 3 disease, one with oligo metastases, probably we should do radiation and continue the same. This was in the stage 3. We don't have also data. I tried to search, and we will ask our colleagues. When we have adjuvant atezo with single progression, we will continue your atezolizumab and radiate the single lesion. Also, we don't have clear answer to those questions. So the summary of our case, stage 3 early non-small cell lung cancer, PD-L1 positive, diagnosed in March 2024. The patient received adjuvant vinorelbine and cisplatin. In July, after no evidence of recurrence, she had 2024 adjuvant atezolizumab was started, and she had BRAF V600E mutation. October, another recurrence, chemoradiation therapy with pemetrexed and carboplatin for 2 cycles. We had a partial response by the end, and the patient was started with durvalumab. We had single brain mets that was appearing, radiosurgery was done, and the patient was currently on durvalumab. Thank you.
Thank you, Prof. Khoury. This was an excellent case, and it's complicated as well. And it's very interesting that specifically for the BRAF V16, we know that those group of patients, they are very resistant. And even you did everything right, but still a lot of questions need to be addressed as well. Thank you. And we'll keep the discussion after Dr. Samah, and it was great. Thank you. And it's my pleasure to introduce Dr. Samah Rahili, my dearest colleague, and she is a medical oncology consultant in Prince Noura National Guard Hospital. She will share with us as well case presentation. Dr. Samah, the floor is yours.
Assalamu alaikum. Thank you, Dr. Mirvat. And I would like to thank also Dr. Muad and Dr. Prof. Khouri. Very interesting cases, to be honest. So my case is actually short. I will start with the presentation. So he's a 52-year-old male who actually had no comorbidities. He's an ex-smoker, diagnosed in December of 2022 with a right upper lobe mass. And the patient actually biopsy confirmed a non-small cell lung cancer adenocarcinoma. His brother, older brother, actually was diagnosed with lung cancer, so the patient actually panicked and he traveled abroad. And all what we have from his history when he traveled abroad is his images and the pathology report. So this is his initial images when he actually at initial presentation. And then when he presented to our hospital, actually he was status post-lobectomy. He didn't receive any neoadjuvant therapy, and his pathologic staging was T4N0 with lymphovascular invasion and pleural invasion into the visceral pleura. His NGS was negative, and his PD-L1 was 20%, and it was an R0 resection. So he had a baseline staging workup, and it did show that he has only post-surgical changes, no disease anywhere else. So we started him on adjuvant chemotherapy, cisplatin, pemetrexed, and at that time, we just had the data of Empower 010 and the PEARLS or Keynote 091. And we know actually both is in the guidelines, so we were actually questioning, should we consider atezolizumab versus pembrolizumab? And the decision was to go ahead with pembrolizumab, given that his PD-L1 status was 20%. Patient actually finished his course of immunotherapy in May 2024 with excellent tolerance, and actually he has no toxicity whatsoever during his immunotherapy course. His recent CT scan in May showed a clear CT scan. He had no evidence of recurrence, and he's now on ongoing surveillance with no recurrence at 13 months. So was skipping neoadjuvant therapy justified in this T4N0 case? And also, would you have pursued neoadjuvant therapy in this patient? Why or why not? Of course, MDT is a key thing in lung cancer, and you need a team for the best treatment choices. And with this, I actually conclude my case presentation. Thank you.
Thank you, Samah. This is very excellent and interesting case. Thank you for the nice presentation. I think now the floor is open for questions. We will take questions from our colleague, the attendee, and we'll take question from the panelists if they do have questions, and me and Dr. Mirvat will also participate in this part. Dr. Mirvat, if you have a question, please go ahead.
Yeah, I would like to thank you, Dr. Nafisa, for sharing this session with me. And I would like to invite Prof. Khouri and Dr. Samah. Unfortunately, Dr. Muaz has an emergency and has to go. And so Prof. Khouri, the case was very interesting, actually. And I think this is a learning lesson about the patient with PRAF V16. We know that this group of patients, we are treating them initially with immune therapy, and then we may go for anti-PRAF, either encorafenib or dabrafenib for this group of patients. Do you think that the patient, of course, the patient has the surgery, and we have atezo, and it was almost 3 months, and then the patient developed recurrences. So it seemed that even with his PD-L1 was more than 70%. So by all means, he was supposed to be a predictive for a response. But however, the patient progressed. Do you think that if we are turning the clock again, this patient, he will go for neoadjuvant therapy, and if we're turning the clock again, you will give the patient anti-PRAF therapy if progress on the atezo or what?
So thank you very much for this question. I think we have, it was peripheral 1.5 centimeter tumor, honestly. And we were surprised to find that the staging, in this case, we don't do practically the EBAS with such a small peripheral tumor. So in our institution internally, we don't do it practically. We have the EBAS, but we are not doing it. So here, and the PET scan was negative, and we consider that it's small tumor. So honestly, here to do the neoadjuvant, it was not indicated. So it's very important to have the good staging, and this is all the issue today with the trend with the perioperative treatment. Second important point that you are mentioning, the BRAF and immunotherapy, as you mentioned, Dr. Mahrous, we know there is a stigma of immunoresistance. However, it's not as clear as we find it with EGFR and probably the ALK also. So also we have some contradictory points. However, I think that I'm not also if we will think about the concept of we had existed, the progression was after 3 months of atheism. However, as I mentioned, after the tumor board and the discussion with the long of stress, also we had this high PD-L1 of 70% that was confirmed also on the second biopsy with high PD-L1. We opted for the strategy to go to as maintenance with durvalumab. When we had also this brain progression, here we have a lot of questions. We have also that the anti-BRAF showed in some studies interesting results by passing the blood-brain barrier. Also, we are very conservative. We don't want to lose lines of treatment. As I mentioned, the family context, the doctor, her son is a doctor. So we are trying to do very close follow-up every 3 months. Now we have the last one with PET and MRI. It was all the results were still in remission. So we are maintaining now the durvalumab with not a lot of conviction. I don't know, what is your comment also?
Thank you, Prof. Khoury. I have a comment. It's very interesting and challenging.
Yes.
It's a very challenging case, actually. My question, did you try to do any biopsy at the time of the local progression? Did you take any lymph node biopsy? And did we repeat the NGS on the brain metastasis?
Yes. So we did, since her son was a neurosurgeon, so he didn't opt to do a surgery. We did a radiosurgery. Okay. So we didn't have biopsy on the brain. However, we didn't repeat, no, the NGS on the progression. We only did the PD-L1. And as I mentioned, it was high. But it's a good idea probably to redo, but I think it's the same one. We will have probably the BRAF, but also with the tumor heterogeneity, it's very interesting. Maybe also liquid biopsy in this case after the brain met will be a very interesting point. So I think that it's a good suggestion now also to find if we have any residual disease also, maybe it will be interesting also to detect it and also to find if we have the presence of BRAF mutation or not.
Perfect. Dr. Samah, do you have a question? And Dr. Mohsen as well. So Dr. Samah, go ahead.
I have a comment actually. Very challenging case, to be honest. And at the time of the local recurrence, the rest of the options that you mentioned is palliative options. So I would, to be honest, still consider if this is a local recurrence, the Pacific approach, because otherwise the treatment approach would be a palliative option. But it's very, very challenging, to be honest.
Yeah, I agree, Samah.
Thank you. And this was also, as I mentioned, we want to give all the chance to our patient. And I'm telling you that we have the immunoresistance, we have early relapse, but this was our strategy. And I think, hope it will be the good one.
I think, the issue that you did everything by like the book, how it's happening. So the patient, he had the surgery, and we do have PDL1 high, more than 70%. You give the patient atezo based on ion power. And unfortunately, that the patient within 3 months, he developed recurrence. And I think this is a learning point that still some patients, even with high PDL1 as a predictor, still we do have a patient consider for them, because this is considered a primary resistance for such group of patients.
Yeah. And definitely the PDL1 is not the best biomarker. So we definitely, there are other biomarkers that we don't know about them. Otherwise, with the 70%, if this is the only positive and effective biomarker, the patient should have excellent response, and at least he should have continued responding for a while. But unfortunately, he progressed very fast. So this tells us very clear that there are other biomarkers that we don't need to know about, and further clinical trials are needed to find out what are they.
Agree totally, Dr. Nafisa. Prof. Mohsen, please go ahead.
Thank you, Khoury, for a wonderful case. Okay, so you did it by the book. Yes, the Empower had patients with BRAF mutation. And like Mervat said, they don't respond well. They're slightly better than the EGFR. Your EGFR response with immune checkpoint inhibitor on its own is 11%. BRAF is 24%. But the median progression is exactly what it did, 3.5 months. And today we have a clinical trial that is probably going to answer your exact question, which is the Horizon 1 trial. They are going to be giving patients as adjuvant therapy with targeted therapy, including BRAF V600 is going to be challenged in that. I would have, after the radiation, either waited. I know in Europe they love, because I've got a lot of patients that have progressed and then they start them on chemoradiotherapy and then start them on durvalumab, even if they do have some sort of mutation. I personally am not a believer of that. I think it's sometimes it's just giving it because we don't have any other clinical trial that says otherwise. But it's probably not going to work. And I think that probably the next time this patient progresses, I'd go on for a BRAF MEK inhibitor rather than continue with the durvalumab. It is one hell of a case, and specifically when we don't have the BRAF MEK inhibitors available readily in our region, unfortunately.
Yeah, it's my perception, like you, Dr. Mohsen, that especially for patients with a driver mutation, I agree with you totally. Also with Umpik that we don't have a good experience with BRAF mutation. Especially in the lung cancer, we start to see cases, but most of the cases, because the front line is immune therapy, as a second line or even for subsequent lines for those patients, we didn't see the dramatic, and this is why when we are seeing in the NGS, we are not enthusiastic to start for such treatment. And I think, like you all said, we still didn't see that the anti-BRAF in lung cancer have the big chance comparable to EGFR or ALK, because now by default we have to give this patient, and even for RET or HER2. And this is very challenging. And the main issue that the patient is very aggressive. And this is bring me, actually, it was one of the questions of the attendees. They were asking, the patient, he has a brain mets, and the patient progressed on atezo. Why you didn't go for a dual blockade for this patient, as single agent is considered weak? This is a hell of question. Thank you very much, Dr. Ahmed El Gendi from Egypt. This is the question for you, Dr. Umpik. So how about, of course, what you did, I will do the same. But the question is, we know that 30%, 70%, and the patient, he progressed on atezo. So how about dual blockade for this patient, especially for the patient has a brain mets, and we know that dual blockade has a good impact on such cases. So what was, and we do have, on the other side, we do have the BRAF as well. So what do you think, pick.
Exactly. So we have 2 points here, 2 limiting points. I totally agree. Personally, brain mets, lung adenocarcinoma, and also if I have PD-L1 negative, I will go for double immunotherapy. And we don't have other option in this case for immuno, I'm sure. And also if we have PD-L1 positive. However, the point here, we have 2 limiting factors, the BRAF mutation and the oligoprogression. So this is the 2 main points that maybe are limiting this option. And I think now, if we have any progression, I will don't go to double immunotherapy. As Professor Mukhtar mentioned, I will go for anti-BRAF and anti-MEK in this time.
Yeah.
Okay.
Prof. Khoury, did you notice any adverse event or significant adverse event as expected to see those in a different way, not like the patient who doesn't have targetable mutation? Usually that is why we just wait for NGS result before committing patient to immunotherapy, because usually they do have more side effect, not like the other patients who don't having targetable mutation. Did you notice any?
No, honestly, no. The patient didn't present any toxicity. She is traveling between every cycle of immunotherapy. She's really perfect. So I think that, but it's a good point also, the toxicity and the presence of some mutation, but in our case, we didn't find any.
That's good. Yeah.
Okay, so I think thank you very much, Prof. Khoury, for excellent presentation. And I will go for my case first, and then we'll go for Dr. Dr. Abdurrahman. So
Rahman.
yeah, I will just start sharing my. Do you still have time, Prof. Khoury, or you need to go now? Because I wanted to. So, if you allow me, I will share my case.
Yeah, go ahead, please.
You can see my slides? Okay. So, thank you all for presenting and sharing your case. Oops. Sorry. I think. You can see my slides?
No.
Okay. Just a second. Okay, Abdurrahman, Dr. Abdurrahman, you can start sharing your, if you don't mind, you can start your case, and I will do after, and then Prof. Mohsen. Okay. So, Dr. Abdurrahman.
Yes, sure. Assalamu alaikum. Can you hear me, everyone?
So, Dr.
Yeah,
Abdurrahman,
we can.
Thank you very much for joining us today. Dr. Abdurrahman Al-Gaban, he is a medical oncology consultant in King Faisal Specialist Hospital and Research Center. He will join one of his cases as well. I need to stop sharing.
Thank you very much for your kind introduction. Thank you for having me among dear colleagues and eminent speakers. My name is Abdurrahman Al-Gaban, Associate Consultant in King Faisal Specialty Hospital in Riyadh. I'm going to be presenting today perhaps a simple case, but something new and have been added to our expansion in lung cancer. So this is Mr. M is a 43 years old male with a significant background history of bronchial asthma, has been stable for several years, chronic hepatitis B on treatment. He presented to his pulmonary clinic with about shortness of breath for 2 months, presenting or complained of persistent cough despite optimized asthma medication, several courses of antibiotic, but no improvement. Relevant history, as I mentioned, he had stable asthma.
Dr. Abdurrahman, we cannot see your slides. You did not share your slides.
Oh, forgive me. What about now?
Yes.
Okay. So I'm gonna go over the presentation. He's a 43-year-old male with bronchial asthma, hepatitis B, presented with a 2-month history of persistent cough, continued and worsened despite optimization of his asthma medication. Relevant background history for stable asthma. He lives in Najran with his wife. He has significant family history of his brother who has advanced non-small cell lung cancer, and he has a history of light smoking of less than 5 packs per year. Physical examination finding was really not unremarkable. Normal vital signs. Physical examination was really unremarkable at bedside. His initial blood work at his local hospital was really unremarkable. However, his chest X-ray showed suspicious mass in the left lower lobe, and for that he was referred urgently to a thoracic lung mass clinic for evaluation. His diagnostic imaging, he had negative MRI, and PET scan was negative for distal metastasis. However, his CT scan showed clearly this left lower lobe lesion, very close to the pleura, estimated size of 5.5 centimeter in diameter. Biopsy was done and showed non-small cell lung adenocarcinoma. ALK by immunohistochemistry was positive, and PD expression was at 5%. For that, he was discussing the tumor board, and the recommendation at that time was for primary surgical resection of the tumor and adjuvant therapy based on his final pathology staging. So just to summarize his case, this patient initial symptoms started in December 2023. Then early in March, he presented to his pulmonary clinic. In mid-March, he was referred to our cancer center. And after completion of his workup, he was presented tumor board, and the consensus was to go for surgery, for which he underwent in April 12. His final surgical pathology showed invasive mixed mucinous and non-mucinous adenocarcinoma, grade 3 poorly differentiated, size was 5.5 centimeter. There was a STAS, lymphovascular invasion was present, but all margins were negative. A surgical pattern, mainly acinar with some differentiation. Final staging was PT3N1 with 2 lymph nodes out of 10 regionally, and the NJS at that time had confirmed that he had ALK fusion mutation. So post-surgically, he was seen about 4 weeks in the clinic. He was recovering well, surgical wounds healed properly. We discussed the adjuvant therapy at that time based on the ARENA trial. We offered him directly adjuvant alectinib 600 milligram PID. I saw him just last week, and he's been doing very well on treatment. No significant really complication apart from which has been managed with just dietary change, and his scans are negative. With that, I conclude my case. Thank you.
Thank you, Dr. Abdurrahman. Thank you for a very nice presentation. I think now, Dr. Mervat, if you're ready, you can go ahead and present your case.
Thank you, Dr. Anfisa. I think Dr. Mohsen, he can go ahead,
okay.
And then I will be the last. Thank you.
Thank you. It's my honor to introduce Prof. Mohsen Mukhtar. Prof. Mohsen is a well-known and eminent medical oncologist. He's a senior consultant of clinical oncology at Cairo University, Al-Qasr Al-Aini, and he will present a case of early non-small cell lung cancer with ALK mutation. Prof, please.
Thank you very much, and it's an honor to be with you all, and thank you for having me. This is my case. It's probably a copy-paste of Abdurrahman's, but she's a female. These are my disclosures. So this is a 73-year-old female who presented to us earlier this year, but she had been complaining of a cough in 2020. So that was nearly 5 years ago. She sought medical advice, and they showed some scarring at that site in 2020. Then this was the X-ray, as I showed you, some segmental lobes, a small very small lesion. They advised her for a CT. She did not do the CT. And then she came in early this year, as I said, in January, with an increased frequency of cough, unintentional weight loss for 6 months. She resought medical advice, presented to us. We referred her for a CT and revealed a left lower lobe posterior segment, well-defined lesion, 2.3 by 1.7. This was her CT scan. It didn't show anything more than that. It did show some hepatic focal lesions, and that's why we did a PET scan. And in the PET scan, it only showed a 3 by 2 centimeter left lower lobe lesion. She underwent a CT-guided biopsy. It came in as adenocarcinoma, non-small cell lung cancer. Now, the first question to the panelist is, do I need to do any genetic analysis for this before I go on for surgery for the patient? And is there any role for neoadjuvant therapy for this patient? She has a very small lesion. We opted not for any neoadjuvant therapy. She was referred for thoracoscopic left lower lobe lobectomy, as well as thoracic lymph node station dissection, which she underwent in March of 2025. Her pathology came in as a T2N0 with all her margins being negative. You can see that she had several of the lymph nodes removed. These were actually up to 6 lymph nodes, 8 lymph nodes being removed, and all of them were negative. Now, I know we're talking about ALK specific, but we are going to need to do biomarker testing for our patients, even if they are stage 1B, and multidisciplinary approach is definitely of importance. And we can see that in the adjuvant setting, we've now got both the Alina and the Adora coming in for these patients that have been resected. Her initial tests were EGFR mutation negative and a PDL1 exactly as Dr. Khouri's 70% positive. Now, would I rush here to give that patient immunotherapy? And the clear answer is no, because this is not enough to initiate therapy. I think since we have the Alina data, we are going to need to do the ALK. And I think hopefully in the coming future, as I said, the Nautica trial is going to address several other mutations that we might get results for very soon. And this came in as an ALK fusion mutations. This patient is a 1B, and we can see that the hazard ratio is 0.21 in the case of giving alectinib for these patients. So the question is, in terms of disease-free survival, we do not have an overall survival benefit yet. This, in some guidelines, has not been put in. So giving the Alina in all of our guidelines has not yet been put in all of the guidelines. So should I go for the Alina even despite not having an overall survival, or should I start off this patient with chemotherapy? I think this is the question to the panel that I'll be ready to tackle. Thank you very much, and I'll stop sharing my slides.
Thank you, Dr. Mohsen. That was excellent case as well, both you and Dr. Abdurrahman. And I think you, Dr. Abdurrahman, addressed a very important issue regarding that lung cancer is even for early cases, driver mutation patients should be treated specifically. And regarding your last question on your presentation, I believe even for a stage 1B, and we do have some data from the Adora, that stage 1B, you may go for osimertinib, as even on the Adora trial, they were giving chemotherapy followed by osimertinib. However, in the Alina, it was only devoted for alectinib. And if I will take the answer for this question, I will give the patient alectinib, specifically that the ALK positive patient, they have the best overall survival in ever comparable to the other driver mutation. And for the adjuvant setting as well, even we don't have an overall survival. But we'll keep this on the discussion part. I will go for my case and will switch the gear a little bit again to the adjuvant part regarding immune therapy. Dr. Anafisa, you can see my slides?
Yes, very clear.
Perfect.
Thank you.
Thank you again for the excellent cases and sharing your experience. We do have a lot of questions from the attendees. Thank you for sharing as well the questions. So my patient is Miss Noura. She is 54 years, Saudi lady. She's married. She has 6 adult children. She's living in Jazan. She's non-smoker and she's mild Chamma user. So Chamma for the people outside KSA, it's like tobacco. And she was telling that it was occasional, family history of malignancy. She had been complaining of worsening of dyspnea and cough, and she was reviewed by her medical team many times, but no specific diagnosis. So the CT showed interval development of left lung mass measuring 5.5 by 4 centimeter, containing some air close to the pleura as well. And it was suggestive for here is the CT scan, and you can see that the patient has significant lesion here, and it was 5.5 by 4 centimeter, as you can see, and you can see also there is no positive lymph node by scan. However, by PET scan, it was confirming as well, and you can see that the SUV, it was 9.5 regarding the lesion. There is no hilar or mediastinal lymph nodes. And in the meantime, when we did for the patient PET scan, you can see that she has also a thyroid nodule. And so it was the main question if this thyroid nodule related to the lung or it is double malignancy as well. And of course, the answer of this question, that we had a biopsy from the lung, and when we had the biopsy from the lung came as invasive pulmonary adenocarcinoma with lipidic component and mucinous differentiation. It was TTF1 positive, CK7 positive, and negative for CK20. And the tumor involves 90% of the material. In the meantime, the FNA and the ultrasound, it was by red 4, and the biopsy came also as papillary thyroid cancer, and the patient from the start was diagnosed as double malignancy. And so the patient was brought to our MDT, like Dr. Marcin said, that all the cases should be submitted. And so we have to have a discussion what the sequence for this patient, what to do. The lesion is considered resectable. The EPAS was carried out as well and came negative. And so the patient was discussed on the tumor board and patient elected because the most serious one is the lung cancer. And so the patient was elected for resection. And she had the lobectomy, and you can see the tumor size was 5.2 centimeter, and it was grade 2 moderately differentiated. And in the meantime, multiple station of lymph nodes came negative. And here you can see that the pathological staging, it was YP, T3 and 0 M node, and it was stage 2B. Patient was NGS negative, and PDL1, it was 10% as well. So the postoperative scan, as you can see, the patient, she had the lobectomy, no residual disease, no collection. And as I pointed, it was stage 2B, 10%, and the patient was elected for putting the fact that the patient, she had the surgery. And so the PTC, even it's a curable disease, we have to little bit treat the lung cancer initial. So the sequence for the patient was to give her chemotherapy on adjuvant base. As the patient, she is stage 2B, and the chemotherapy type was elected as alimta-carboplatin 4 cycles, followed by thyroidectomy, and then we'll consider for the patient the atezo by 1 year. The patient, she had the thyroidectomy, and luckily she was a stage 1 disease. This is the thyroid scan, whole body scan after the thyroidectomy, and came negative, and so she was not candidate to receive any iodine and just only follow up. And the patient, after this, she was receiving atezo, and she received 1 year, and the last cycle, it was in March 2025. The patient, she was having double malignancy. She is in performance 1. She's doing very well. And you can see here, this is the PET scan in May 25, last month, and the patient, she is free of disease. Regarding the toxicity profile, so the patient, of course, she had fatigue grade 1, hypothyroidism, and also nephritis grade 1, and it can be also precipitated by the pemetrexate. However, all these manifestations was recovered nicely. I will not go a lot because we do have a keynote lecture by Prof. Ignacio and also Dr. Nafisa. So the IMpower 010, as it was presented by Prof. Khoury, that it was the first study to address that the immune therapy for this patient can be, and they have disease-free survival benefit as well. And you can see that the study was randomized 1-to-1 for the patient who received 4 cycles of chemotherapy. And you can see that the study met the primary endpoint as the disease-free survival. And you can see from the start, there was a separation of the curve 75 versus 60%. You can see that they included patients with EGFR and ALK as well. It wasn't large population. And when we look here, we can see that the higher the PD-L1, more than 50%, the better the outcome here, putting in fact the hazard ratio, which is in contradict with the Pearl study, as Dr. Samah presented for the PEMPRO. So in the PEMPRO study, it was the, switching. The patient was PD-L1 less than 1%, that they are doing better. Then, more than 1% here is better than more than 50%, which is contradict about what we have before about PEMPRO. The overall survival not reached, and you can see hazard ratio of 0.7, and we know that the more benefit regarding for the patient was more than 50%, and this is why they have EMA approval, and patient was more than 1% for FDA approval, and this is the conclusion with the IMpower. What I wanted also to put on consideration that the ctDNA, which is supposed to be shortly, that the patient with ctDNA positive after resection, those patients, they are doing worse comparable. However, the patient who received the atezo, you can see irrelevant of ctDNA, either positive or negative, they have benefit from atezo, and the benefit is more for the ctDNA positive patients. Sorry, negative patients, they are doing better. And you can see here regarding the PFS and also the PD-L1. For the PD-L1, more than 1% here at the median DFS, it's 21, comparable to 7.2 with the PIS supportive care. And this study, it was published in Lancet Oncology many years ago. Thank you very much for your attention.
Very much, Dr. Merbet, for this excellent presentation. I think now the floor is open for discussion, and I advise to encourage everyone to discuss.
So we're switching the gear now, but I think we have the main topic is the adjuvant therapy. And Dr. Abdurrahman and Dr. Mohsen, they pointed a very important element regarding the ALK positive patients. And we know that those patients, the issue that there was some data that, and it was addressed, that the patient on adjuvant therapy with alectinib, they may have toxicity regarding the nausea and vomiting and the liver functions. However, we do have almost like 10 years of alectinib on a metastatic base. But we didn't see that, and we found that in some data regarding the real world data, and also it was start to be repeated. Do you guys find it's this, because we didn't see any problems with the patient with alectinib on adjuvant base. So, this question for you, Abdurrahman, as you are presenting first regarding the ALK positive patients.
I experience, I don't have as much as adjuvant alectinib patient as much in the stage 4. But in my experience, the most common reported side effects that I have seen in my patients is actually constipation. And it's often very ignored because it's felt and thought to be something related to diet, but it's well known documented side effects of alectinib. And I always ask my juniors to check for constipation. It could be mild, the patient himself ignores it, but it can be sometimes very devastating for them, or at least compromising their quality of life, without actually realizing it's related to this medication, how to optimize it. But the nausea is not as much as reported. Even the liver enzymes, I have seen them so far in my limited small number of patients. Of course, keep that in mind. Not as much. I actually see that more in metastatic, but I see some nausea, some liver enzymes, dearrangement that settles down throughout later. But it's more of a, so far has been a pleasant ride so far, I guess.
Of course, we do have the trial. It's clear regarding the patients for the adjuvant therapy, and it was comparable with the chemotherapy, and it was only 2 years. The issue that for the patient with high-risk population, as we calling, the patient with a stage 3A high grade, or patient with lymphovascular invasion, or those patients with pleural invasion. So you think that those patients, and we know also the ALK positive patients, they are responding well to chemotherapy, especially the Alimta or pemetrexed. You didn't think that the patient with a stage 3A or the patient with high-risk group who went for upfront surgery, and as Dr. Mohsen pointed, that maybe we consider the neoadjuvant for this group as well, until we do have this data. For the patient, we are feeling they are high-risk group for recurrence or for based on the pathological criteria. You didn't think that maybe we go for chemotherapy followed by alectinib, or we need to stick to the data and the guidelines, and of course, especially that we don't have yet a mature overall survival.
I agree, and I think the question of chemotherapy is always there, and we always would like to think about giving it, especially that the ADORA trial did show that there is some benefit on top of the chemotherapy. But unfortunately, the design of the MENA trial did not allow for it was just directly alectinib versus chemotherapy. Something very specific to alectinib patient, although the EGFR patient do have it, but the ALK positive patients, they have very strong tendency to have CNS relapse or metastasis. And I think that's one of the very strong, compelling reason to give for even for early stage as much as I can to give them adjuvant alectinib, because really CNS recurrence or CNS metastasis is really very detrimental in their prognosis and their outcome later on. And this has been clearly shown in the early results that the CNS-free disease has been significantly reduced. And I think that by itself is very important. So yes, despite the other high-risk pathological feature that we find, I think ALK positive by itself is a high-risk feature, or high risk for future recurrence. So perhaps maybe this can mitigate the need for chemotherapy early and just start for something that can cover or protect the CNS as early as you can.
I agree totally.
I totally agree
Yes.
with Dr. Abdurrahman, and I'm back to Prof. Mohsen question. I will not be hesitant to start alectinib as adjuvant, even in stage 1B. We know those patients have tendency to develop brain metastasis, and in the trial, alectinib was found to have some sort of protection. And the second thing, that those patients might progress, and we don't know what kind of progression we will be having. In the metastatic setting, if we start the patient the first line, maybe 60% of them will not make it to the second line. So the earlier the better. So the adjuvant will give more advantage, at least increase DFS. And here, I'm not worried if there is no overall survival. This is the metastatic setting, of course. But for the ALK, we do have subsequent therapy. If the patient develop disease progression while he's on adjuvant alectinib, you have other options. You have other ALK inhibitor like lorlatinib. Although we don't know, we have to do biopsy and know exactly what was the type of resistance. But still, if the patient continue to have ALK positive and no other mutation, you might go for other ALK inhibitor. So I will not be hesitant to start adjuvant alectinib even in stage 1B cancer.
Yes.
Thank you, Dr. Nafisa. Coming back to your point that patients with on the adjuvant therapy have more side effects. I think this is in all types of diseases, because in the adjuvant therapy, the patient feels that he's taking this without there being any disease. So every little side effect
Yes.
he complains about.
Yes.
While in patients with the metastatic, I think they are more reluctant to complain because the drug is working. I think this is with every of our adjuvant therapies, not just with alectinib, but you do see some constipation, you do see some elevated liver functions, but I don't think they are higher than those as seen in the metastatic setting.
Yes, perfect.
I think
do you want to?
Yes,
go ahead.
Yes.
Thank you. Very interesting cases. Actually, I have a question. Thank you, Dr. Mirvat, for raising the question of adjuvant chemotherapy and Alina. Alina made it very easy by actually going straight to alectinib. My question is regarding ADORA, because we know in ADORA around 40 to 45% of the patient did not receive standard adjuvant chemotherapy. So, and they get benefit irrespective of if they received adjuvant chemotherapy or not. Do you feel comfortable by the data we have to actually go upfront to osimertinib, or do you prefer to offer the perfect candidate for chemotherapy and then to jump to osimertinib?
I think it's stage by stage. My personal take is stage 1, stage 2, I go to osimertinib. Stage 3, I still will offer chemotherapy for these patients. But I don't know whether it's really beneficial, or am I just doing it just to be protective of myself rather than it really being beneficial. I totally believe it's the osimertinib that's doing the job, not the chemo in this case.
Yeah, I voted the same like you said, Dr. Mohsen, that I believe that the higher benefit, it's going for the higher stage. Once we reach to stage 3, I think this patient, they need the sequence of therapy. However, we still little bit, we have to be cautious because the study was designed for the chemotherapy followed by osimertinib. And if you wanted to go to the same spot there, we have to follow the lead. But however, we still have a space for the patient who's not candidate to receive chemotherapy. We'll just go for osimertinib and we can be comfortable about this part. The Alina, as Samah pointed, that the Alina made it for us clear and also more confident that if you are giving comparable to the chemotherapy. And I think the issue that, as I asked Dr. Abdurrahman, and it was for you also, Dr. Mohsen, for the patient with a stage 3A high risk group, we need to go only for the alectinib for these patients, single agent like the study, or we may go for the sequence as well. We have to follow the lead. We have to follow the clinical trials and the guidelines. They are securing this. However, we don't have an overall survival. But I think we need more data, specifically, like you said, neoadjuvant may solve the issue. What do you think, Prof. Gilbazo, for this part? Prof. Ignacio, thank you very much for joining. You missed a lot of exciting cases, but actually, we're always happy to have you. You are muted. We didn't hear you, Prof. You're still muted. I think you have some issue regarding the voice. We couldn't hear you, Ignacio.
So,
yeah, now it's fine.
Do you hear me now?
Yeah, we can.
Sorry.
No worries.
Yeah, first of all, I would like to thank for inviting me and to having me once more. And also to say sorry because I had a problem with my laptop and I just couldn't work. So finally I was able to connect and so sorry for being so.
No worries there.
Right. So excuse me.
I think the voice little bit far away. If you use the mic or something, because we hardly can hear you, or it's only me.
No, it's all of us. That's why it was.
Yeah, we couldn't hear you well, Prof. Gilbazo. Can you please join again or change the mic because it's a little bit far away?
Till Dr. Gilbazo changes the mic, maybe. I think you have to understand that whether or not to give the new adjuvant totally depends on your surgeon. Again, the surgeon is really important. Can he resect that 3A or does he need new adjuvant to decreases? With the EGFR now, we have the new ADORA that is coming into play as part of the new adjuvant setting. Are we going to see the new Alina come into play as well? Probably yes. But again, if your patient is ALK or EGFR and you're going to give chemo, don't add on the immune checkpoint inhibitor. That's just my take from that. And it all depends on the surgeon and what the surgeon that you have at hand can do.
Yes, agree totally. Ignacio, did you still muted?
Yeah, I think I was able to manage the mic. I'm so sorry.
No worries.
It's very clear now, yes.
Okay, so sorry. So, yeah, I will say that I'm really thankful for me and also so sorry for the late. I had a problem with my laptop. I hardly could work it, and so finally I was able to connect. So sorry for having you there waiting. So your question was regarding the anemia or the adjuvant.
What?
Do you hear me? Because I think somebody muted me.
The voice
I
is
think,
not
Prof,
clear.
you have an echo in the voice.
Oh, okay,
You
but
look out and come back, Ignacio. I think you have some issues with your connection.
okay, but you can hear me, right?
No worries. We'll wait for you.
Okay.
I can. We can address the
Maybe it's better now.
cases. Yeah, I think this is better.
All right. Sorry.
Okay, so we'll go for the cases for the. We have two cases for opinion. I would like all the faculty to give us their input as well. So we have two cases. One case from Qatar. Dr. Nafisa, you can see the cases?
Yes.
Okay, so the first case from Morocco.
Yes, please go ahead. Yes.
So we do have two cases from the attendees. They asking for an opinion, and so we asking all we'll do have a voting regarding the treatment, and then we'll ask the faculty. Okay, so the case number one from Morocco, Dr. Zena bin Youssef. So she is, the patient is 63 years old male, diabetes mellitus, hypertension, CKD, performance echo-1. The patient, he was diagnosed as advanced non-small cell lung cancer adenocarcinoma. The tumor size was 4 by 5.2 centimeter, so it's almost T3, and the left hilar lymph nodes and solitary bone deposit in the left scapula. The patient was PD-L1 10% and NGS negative. The patient was treated with SPRT, the solitary bone lesion, and then they started chemoradiotherapy. So they consider the patient as local advanced with oligometastasis. However, he is supposed to be considered. Anyway, I will just go ahead with the case. So received the SPRT to solitary bone lesion, then started chemoradiotherapy, and they give the carboplatin etoposide. A patient has disease progression, so they follow the Pacific protocol. Patient has disease progression during the radiotherapy with increasing in size of the lesion, and he developed supraclav as well lymph node, and this is considered new. So the patient, he was initial with bone deposit. They give him SPRT, and then they consider as local advanced. They follow the Pacific, and they were planning for this, and then the patient progressed during the treatment. And I just wanted to remind you that the Pacific, that the patient who responding to the CCRT, they have to go for the immune therapy. However, this patient, he is progressing during. So the patient performance echo 1 to 2, what is the recommended regimen? And Dr. Zena, she was asking and giving us the choices. So what is the subsequent therapy? Nivolumab single agent, Pembro, Alimta carboplatin, Nivo Epi, Alimta carbo, chemotherapy alone, Atizu, Bev, Taxol carbo. Nurhan, do we have voting?
Yes.
Okay. So can you show us the voting? So we'll ask the guys attending with us. We will ask for voting. Can you please show the voting? So what is the subsequent therapy for the patient? Durva, Pempro, alemta-carboplatin, dual blockade, chemotherapy alone, or atezo, bev, taxol, carbo. Can you please vote? Can you give us the result, please, Nurhan?
The vote is not working for some reason. I don't know.
The voting is not working for the panelists. It's for the attendees, doctor.
Oh, okay. I'm sorry.
Okay, so most of the attendees, 33% voted for Dorva single agent. And so they are following the Pacific. I just wanted to remind you guys that the patient progressed, and now we do have Sopracare. Or we have almost equal regarding the 17% regarding Pempo, Nivo, Epi. And so what do you think, Prof. Ignacio, how to do with this case?
So definitely for those patients progressing, as you just mentioned, to chemoradiation, those patients are not pretty good candidates for immunotherapy alone, since they are actually they are outside the specific trial scope, and the benefit has not been demonstrated. I think we have to consider patients as first-line metastatic disease, no matter what the patient received prior to this, right? So typically, the patients, according to the PD-1 expression, should receive either immunotherapy alone, in case of PD-1 expression 50% or higher, or chemo plus IO. In Europe, for example, we don't have the option to treat patients with low PD-1 expression, such as this case, 10%, with immunotherapy alone, okay? And at the same time, only few patients can be treated with the combination, chemo plus IO, when PD-1 expression is really high, 60 or 70%, for example. So according to that, this patient in Europe would be treated with chemo-IO combination as the top option. You're muted.
Dr. Mohsen, yeah, agree totally, Ignacio. Prof. Mohsen, what do you think about the choice?
I totally agree with Professor Ignacio. I wouldn't give a single agent in this case. I don't think it's going to work. It's already, once you fail on immunotherapy, do another NGS, make sure that there's nothing there in terms of mutations. But a combination chemo-immuno might be my choice, or combination chemo on its own.
Samah, what do you think?
Thank you. I would agree with my colleagues, actually. I will approach it as a metastatic non-small cell lung cancer. So either to go with the Keynote or Checkmate 9LA, both is a reasonable options.
Both the same. I will go for dual blockade with this aggressive disease. I give the patient the best chance. Thank you very much. I think it was clear, Dr. Zena, regarding the case, and thank you very much for asking us. We'll go for the second case. This case from Tabuk, 72 years gentleman, and Dr. 72 years gentleman, performance 2, ECOG 2, diabetes mellitus hypertension as well. Patient is known colon cancer since 2022, stage 3 disease, high risk, sigmoid cancer. Patient has low anterior section post-surgery and adjuvant therapy, Zelox by 8 cycles. And during this period, he was under follow-up. The CA19 CAA became higher, as the normal is 3.2, became 19.6, and the CA19-9, the normal is 32, became 78. The CT scan showed the solitary lung lesion. And the patient was discussed on the MDT, and they considered that it may be considered metastatic. And so they voted for Widger resection. And the Wedge resection showed 4 by 3 centimeter tumor, and post-operative pathology showed adenocarcinoma grade 2 of lung origin, and the PET scan and all scans are free of disease. PD-L1 5%, NGS came as ALK positive. So this is a double malignancy. And how we treat this patient. Can we see the voting, please? Norhan? Okay. So how to treat this patient? Surgery, as we are not sure that it is a radical surgery for the patient. So he just only had wedge resection, or to go for alectinib single agent, as the patient, he was T2 and 0 and node based on the pathology. Chemo followed by alectinib or observation. This is the choices. Can you please vote? We have 30 seconds to vote. Please vote. Okay. Orhan, can you please show us the results? So resurgery 17%, alectinib 11%, and 61% go for chemo followed by alectinib. Guys, you are I'm not sure this is correct.
Okay.
11% observation. I will start with you, Nafisa. What do you think is the best choice?
I think the best choice, as long as the patient is fit, he should go back for proper oncology surgery. He should have better resection. And then with alectinib for
I just wanted to remind you, he's 72, Nafisa.
Yes, yeah. If he cannot go for surgery, that's why I said, if the performance is allowed to go back for proper surgery, you can go ahead and do that. If the performance is not allowing us, we can consider chemo followed by alectinib adjuvant for 2 years.
Yeah, I will. Yes, agree, Nafisa. So, Dr. Mohsen, you pointed that the key leader for this part is the surgeon. So, do you voted for resurgery again, or you will go for alectinib? This patient is 72.
Again, the patient can, if he can tolerate surgery, yes, surgery again, and then push him off for alectinib. But I would try my luck with surgery, yes. If not, maybe radiotherapy, if it's feasible to give radiotherapy for it.
The wedge resection, it came negative for the margins.
Okay.
Sorry.
But do you have an idea about the lymph nodes?
No, he didn't went for any staging or the stations. Unfortunately, Prof. Patan, he's not with us. We wanted to ask about this element. But it was wedge resection. So there was some data.
Wedge resection with negative margins?
Yes.
Do we have anything on the PET scan? Do we have anything?
All negative, yes.
All negative.
All negative, yes.
Pushing for alectinib.
If the patient can tolerate mediastinoscopy, why not? I don't know. Maybe if the patient is fit to go for surgery
EPS negative, PET negative. Yeah. So
okay.
Yeah, because it was again they went as it's considered like a solitary lesion, and then it's colon. They didn't put in their mind it can be another primary, because the patient, when he did the surgery on the 2022, there was the CT scan at that time, it was negative, and the follow-up scans, and when the patient, his markers going up, and they did for the patient scan, they found this lesion, and so they considered this is a metastatic colon, and they asked for metastatectomy. So they did wedge resection, but came as a primary lung. So, yeah, this is the point. So, what do you think, Fnasio? You vote for surgery, or you vote for alectinib, or chemo followed by alectinib? 60% of the 60% of the attendees, they are voting for, I think they may consider Adora, not alectinib.
Right. So, well, I think, this is one of those cases in which, you can consider whether surgery and the type of surgery can be relevant or not. And then what we know is that patients with ALK positive should receive alectinib. That is something that we know for sure. So, it is a completely different case as we compare to, for example, the ADORA trial, right? Which is, surgery followed by the proper treatment and alectinib, right? So yes, definitely, this is a case in which surgery probably was not, the proper type of surgery the patient should need, right?
Yes, sure. Okay. Thank you, Dr. Mohammed Suhaibani, and for sharing your case and opinion. And I think, the committee voted, if there is possibility of surgery, it will be better. If not, we'll go for alectinib as a single agent for the patient as well. So, because of the time, we'll just تفضلي دكتورة نفيسة. Go ahead.
Yeah, okay.
Yeah, we can go ahead with the agenda. I think on the road, Dr. Walid Salwi.
I think Dr. Walid Salwi.
Go
yes.
ahead. Please introduce him. Please.
Yeah, I'm glad to introduce our friend and colleague, Dr. Walid Salwi. Dr. Walid is a senior consultant of medical oncology at King Fahd Specialist Hospital, Dammam. Dr. Walid will present a case of early stage non-small cell lung cancer.
Thank you, Dr. Nafisa, and thank you, Dr. Mervat, and thank you for kind introduction and invitations. I present one of my real-world case. This is a patient. Are you seeing my slide?
Yes, we do. Yes.
Yeah. This is a 59-year-old female non-smoker presented with a few months with history of chest wall pain, no dyspnea, mild cough, weight loss 7 kg. Examination-wise, she has ECOG 1 and work up with a thoracic team. CT scan was done, MRI and PET CT scan. And that is the chest X-ray, and this is the CT scan, shows there is a left lower lobe necrotic mass obtaining the adjacent segmental vascular pulmonary branches associated with left hilar lymph nodes. But then we do, this is a CT scan, then do CT brain, no evidence of intracranial metastases. PET CT scan only show there is no active lymph nodes, only this lesions, avid lesion represent the primary lung. CT guided biopsy was done. Then our patient discussed in the MDT tumor board, and the tumor board advised to go for surgery. That time came as tumor size 5.5, T3 N0 M0 stage 2B, based on the NINT, and about the new 8 NINT TNM staging is stage 2A. Finally, she did the left thoracotomy with lower lobectomy at 24 of July 2023. Then she is a case of the lung cancer, squamous cell carcinoma, stage 2A, and what next after that? Any things can be do for these patients. I'm asking about any further molecular testing, any chemotherapy. Patient do NGS was negative, PD-L1 was 60%. Then discussing our tumor board, what else about the adjuvant therapy? As you know, the rule of the adjuvant therapy in those patients with chemotherapy for cycle, and the rule, I will not repeat that things. I think Prof. He will mention, and he will talk about adjuvant immune therapy in the resectable lung cancer. But we know the idea of the adjuvant therapy for eliminate micrometastases. And this is how is the long way to improve outcome in the chemotherapy area, to start with all of those trials looking for the immune therapy, and then moving for the adjuvant immune therapy. With this, all survival benefit of adjuvant chemotherapy increase with advanced stage disease, as you know. This is the neoadjuvant therapy. How is neoadjuvant versus adjuvant therapy for those patients with adjuvant therapy? I'm just mentioning that for the new approach of preoperative approach now in 2025. This is the immunotherapy talking about the pembro atezolizumab in the adjuvant setting. And based on that, this is all the trial of the adjuvant therapy, Empower 010, Keynote 09, and also the Nadim about the both the neoadjuvant therapy. This is the all of the phase 3 adjuvant trial in the immune checkpoint inhibitors in resectable lung cancer. Our decision to go for adjuvant chemotherapy, platinum-based chemotherapy, cisplatin gem, both for cycle is doing very well. Then talking about what else, BDL1 is 60%. We are talking about giving the adjuvant immune therapy for resectable lung cancer. As you know, those adjuvant immune therapy based on those two trials, the Empower 010 and Keynote 091. This is the Empower was presented in the ASCO 2021. This is the schema of the protocol, looking for all of those patients and even BDL1 positive for a different category with more than 1%. If you are looking also for different type of the EGFR mutation, ALK arrangement in those patients to start with, and different BDL1 status, looking more with a benefit for those patients with TC more than 50%. If you are looking for this overall survival BDL1 more than 50, the most benefit those of 17% at 5 years with hazard ratio 0.42. This led to the FDA approval of the Atezo in the adjuvant setting of the resectable lung cancer, and also pembrolizumab, another immune therapy in the resectable disease. This is the PET-CT scan follow-up for patient in December. And then this is a patient with December 2023, adjuvant Atezo with infusion every 3 weeks, then completed 16 cycle of chemotherapy. Follow-up CT scan in May last year, no evidence of nodal metastasis or distant metastases. And this is the PET-CT scan in the November last year, no evidence of the disease, is doing well. Are again the questions, some of those patients need adjuvant therapy. We are talking about both new adjuvant chemo radiation therapy, chemotherapy, immune therapy for those patients with ctDNA positive disease. This is martinib and alectinib positive cancer. Thank you.
Thank you, Dr. Walid. That was excellent presentation as well. And thank you for sharing your case. We'll go for Dr. Abdel Nasser Nourallah. Dr. Abdel Nasser is medical oncology consultant in MENA Hospital in Dammam. He will share one of his cases as well. Thank you very much, Dr. Abdel Nasser, for joining us. The floor is yours.
Okay, thank you for the introduction. I'm in Al Khobar. We have 5 branches. Also, we have oncology center in Dammam as well. But I will go for this case ruling in adjuvant non-small cell lung cancer, but we're going to talk about adenocarcinoma. This is a 63-year-old Pakistani male, former smoker, 4-pack per years, quit 3 years ago. Comorbidities, hypertension, well controlled with medication, ECOG 0. And he got the presentation of this case, incidental finding on chest CT during cardiac workup. And CT chest, there is 2.8 centimeter right upper lobe mass. PET scan done, hypermetabolic right upper lobe lesion, no mediastinal or hilar uptake, brain MRI, no meds. Biopsy was consistent with moderately differentiated, well-differentiated adenocarcinoma. It is stage T1, CN0, M0, stage 1B, bare image. EGFR all close 1 all negative, BDL1 60%, and TBS 22 C3. Other markers RAS G12C mutation has been detected. So he went for surgery after MDT meeting, right upper lobectomy and mediastinal lymph node dissection. Pathology, it is 3 centimeters, so in the surgery the size slightly bigger, adenocarcinoma, visceral pleural invasion, so pathological T2A and 0, margin was negative, and 0 of 12 lymph nodes were involved. BDL1, TBS 60% confirmed on surgical sample as well. Final pathological stage is 2A, T2A, N0, M0. So the decision making here, intermediate risk for recurrence due to 2 T 2A size and visceral pleural invasion. Patient fit, his performance status is not bad. Patient fits for chemotherapy and immunotherapy. So you get 4 cycles of chemotherapy, cisplatin, methotrexate, which completed, and then we start adjuvant immunotherapy and atezo 1200 milligram every 3 weeks, supposed to be for 16 cycles, 12 months, almost 1 year. Initiated 6 weeks post chemotherapy. And this is based, as Dr. Walid said, and empowers included patient with stage 2 to stage 3A and selected 1B more than 4 centimeter non-small cell lung cancer, regardless of histopathology, adeno or squamous. And chemotherapy is only, the other condition is to have PD-L1 more than 1% group. The greatest benefit in PD-L1 over, which is over 50% subgroup, FDA approved back in 2021
Give it to
for PD-L1.
for him. Let him open it and take from
More than 1%, excluding EGFR and ALK translocation. Never, even I have patients with 80% PD-L1 expression, and I get ALK translocation. The worst thing to do is to start immunotherapy in this patient. You have to go directly to alectinib or chemotherapy with alectinib, but the patient can go directly to alectinib in metastatic setting. So this is Empower 010. It's been we have seen it. This is adjuvant atezo versus space supportive care in resected stage 1B to 3A non-small cell lung cancer after adjuvant chemotherapy with all 4 cycles. And the benefit is more, the more the PD-L1 expression, the more the benefit is. So the planned follow-up imaging every 3 to 6 months, monitoring for immune-related adverse events, especially pneumonitis or thyroiditis. Patient remains recurrence-free at months treatment, mildly hypothyroidism managed. However, this patient, just I'm giving you the way to go. This patient completed 2 sessions of immunotherapy. And so basically we could not continue the treatment because he got medical termination and he had to go back home. So we gave him the report to continue immunotherapy in Pakistan. And this is the, teaching points. Consider adjuvant atezo in resected stage 2 to 3A, sum of 1B of 4 centimeter or more, PD-L1 more than 1%, EGFR ALK negative, and post chemo. Close toxicity monitoring is key. Ongoing trials may further define benefit in earlier stages and non-PD-L1 expressors. Thank you.
Thank you very much, Dr. Abdel Nasser, for the teaching points and your points as well. So this patient, if you are considering this patient, he received the adjuvant therapy, and so the patient, he started to unfortunately to develop metastasis. What is the subsequent therapy for him? Especially, we do have now the CRIST study, which is launched in ASCO regarding Pembro plus Adrasep for such patient as an upfront for the G12C, specifically for this group of patients. However, the patient, if he receive immune therapy, he may be not candidate for this trial as well.
Exactly. You get PD-L1 inhibitor, and this trial is with PD-1 inhibitor, but still both of them are immunotherapy. I don't think it would be, candidate to be involved. However, if he had received immunotherapy like over more than 12 months, we may reconsider re-challenge with Keytruda or Pembro in this case. But if he progresses early, like within less than 12 months, I think, as I know, there's no rule for adding a different type of immunotherapy, at least as of 2025.
Yes, okay. And Dr. Walid,
a different point of view.
yes. So, Dr. Walid, you will consider only atezo or the immune therapy for patient with a higher PD-L1 because both cases, you and Dr. Abdel Nasser was high as well. So you are with the EMA approval more than 50%, or you will give %, especially that in the study for IMpower 010, they were included almost 13 patients with 1B. However, the analysis we started with to see from stage 2 and 3A as well. So you are considering for all the patients or only higher expressor, Dr. Walid? You still with us? I think he left or he's out. Okay. So what do you think, Prof. Gilbezo, regarding the percentage of expression and giving the treatments?
So the truth, as you just mentioned, is that for the EMA region, we are restricted in the way we can actually indicate adjuvant atezolizumab for those patients with stage 2 to 3A and PD-L1 50% or higher. So only high expressors actually can benefit in the EMA region. And that's probably, I mean, it makes sense if you consider that the patients most likely benefiting from this strategy are those with higher PD-L1 expression levels, right? But the truth is that, and this is something we've seen also in the metastatic setting, some patients with low number or low expression levels of PD-L1 expression can still benefit from immunotherapy. And the reason for this is that sometimes PD-L1 expression is heterogeneous within the tumor. So it really depends on whether you are biopsying or you are studying the part of the lesion in which the PD-L1 expression is higher or not. And, you know, this is something we actually normally ask our pathologists to do with the resection piece, right? We normally ask them to look for all the piece. And this, for larger tumors, might be, you know, more difficult.
Very difficult. Yeah.
Yeah, but still, I think it's worth doing because sometimes if they just take a small sample of the whole piece and they say, okay, 10% or 20%, maybe if they select another area of the tumor, you might actually have higher PD-L1 expression levels. And this is also the case, and there are some interesting studies from surgical specimens addressing how PD-L1 expression levels are in the primary tumor, in the mediastinal lymph nodes resected in the same intervention, right? And sometimes there are completely different PD-L1 expression levels, and the mediastinal lesions can be positive, but the primary tumor is a low expression, for example. So I think it is worth it, and probably we are, we are restricting benefit to those patients that, even though with lower PD-L1 expression levels, might still be benefiting from adjuvant atezo.
Yeah. Especially it's very sometimes technically difficult to do the whole sample or whole tumor PD-L1. Sometimes you have a shortage of staff; they cannot accommodate all these things. Maybe that is why sometimes, yes, we go with any positivity of PD-L1 and give the patient the adjuvant atezolizumab.
Yes, agree totally. Okay, I think we are going a little bit late from our agenda. It's our pleasure to introduce again our dearest professor, Professor Ignacio Gilbezo. Professor Gilbezo, he will give us a talk today about immuno IO adjuvant therapy in early non-small cell lung cancer. Prof. Gilbezo, he's known for everybody. He is one of the key leaders in Europe, and he is a professor in Spain. Director of Department of Oncology and Professor of Medicine in UCB University, Valencia, Spain. Prof. Gilberto, thank you very much for joining, and the floor is yours.
Thank you very much. Again, thanks a lot for the invitation. It's always a pleasure to be part of this tumor board or this thoracic meeting. So it is true, things have changed a lot over the last few years. And now adjuvant therapy with immunotherapy in early stage non-small cell lung cancer is actually the way we should treat most of our patients. So these are my conflicts of interest, and this is the index I would try to cover with a brief introduction to early stage non-small cell lung cancer. I will also touch on the role of MDTs. I think this is important, not only for neoadjuvant or peri-adjuvant immunotherapy, but also for adjuvant therapy. And also, I will try to cover the role of adjuvant immunotherapy in these resectable subgroup of patients and some take-home messages. So, truth is that and this is something we did at the Institute of Oncology in Valencia. We were one of the institutions in Spain, actually the second institution is in Spain adopting the lung cancer screening programs with low-dose CT scans. And as you consider, as 2022, we were able to screen more than 8,000 individuals with certain, predisposition to develop lung cancer. Among those, as you can see there, 67 lung cancer in women were diagnosed, and 172 lung cancer cases among male were also, diagnosed. But most importantly, and this is something that has a lot to do with our talk today. As you can see there, more than 80% of the patients, in fact, were in stages 1 or 2, and 16%, a little bit more, were stage 3. And this is, in fact, the main, endpoint of a screening program, to be able to diagnose earlier our patients. And not only that, but also segmentectomy and lobectomy, so less aggressive surgical procedures were able to be performed in around 80% of the patients. So what does this have to do with our talk today? Well, this means that when all countries, all institutions, all regions in the planet incorporate lung cancer screening programs, we are going to see more and more patients with these early stage non-small cell lung cancer. So in these patients, we will have to make the decision on whether to go for neoadjuvant to adjuvant, whatever, right? So, and this is, depending on the region in the planet, you find some countries in which more than 85 or 90% of the patients are diagnosed in stage 4, because patients are typically diagnosed really, really late in the disease course. So when we incorporate lung cancer screening programs such as this one or any other running currently in the United States or Germany or France, or even the pilot studies being run here in Spain, we'll see more and more patients in this specific setting in which immunotherapy in one of the settings, neoadjuvant, adjuvant, peri-adjuvant, will be actually implemented. And of course, when you are able to diagnose early and to treat earlier, not only resections are less aggressive, but survival actually improve. As you can see there, stage 1 and 2, which were most of the patients that we were able to diagnose within this screening program, showed a maximal benefit and a reduction, around 20% reduction in the risk of death. Very similar to a mammography, for example, for breast cancer screening programs. So when we have an early stage non-small cell lung cancer, the role of MDTs is crucial. These patients actually need to be diagnosed and treated and managed in this way. And the reason for that is that when we do that, as you can see there, MDT management is an independent prognostic, favorable prognostic factor. And patients actually live longer. It has a clear impact on OS when we manage those patients within a multidisciplinary tumor team. So that's why that's important. And I encourage you to work always within your MDT to present the cases and to manage the patient in that integrative, comprehensive way. And of course, this is something you all know who should be part of the MDT, but it can be even more complex. And if you look at the program they have at Gustave Roussy in Paris, France, you see that within the Thoracic Tumor Board, they also incorporate the molecular tumor board, but also the immunotox board with dermatologists, with cardiologists, with many other rheumatologists, etc., trying to manage that immune toxicity that can actually happen, or if they even have for fertility board, etc. So it can be really as complex as you can do it in your institution. But at least MDTs are the core facility in which this or team in which these patients should be managed. So we have a patient that is diagnosed with resectable non-small cell lung cancer, thanks to let's say a lung cancer screening program with low dose of radiation CT, and it is managed within the multidisciplinary tumor board, and the patient is finally treated with surgery. What should we do apart from that? Is there anything else we can do for this patient? Is immunotherapy part of this equation? Well, you know that things have definitely evolved over time, and there are different approaches. We have the neoadjuvant approach, we have the preoperative approach that typically has preoperative and adjuvant treatment. We have the purely adjuvant setting, and we are working here for this talk in that specific space of adjuvant treatments with immunotherapy after surgery. So it is important also to remember that there are clear mechanisms of post-operative immune suppression among patients following resection in the lung. And, we know the primary tumor is important for that activation, but also the lymph nodes can be very important. And specifically, we know that in the postoperative setting, we have higher PD-1, CTLA-4 ratios. We have a lower number of T cells. We have a reduction also in the number of NK cell and its cytotoxicity. We have T regulatory cells increased. Myelo-derived immune suppressor cells also increased, and M2 macrophages increase, and a whole bunch of interleukins that can decrease that activation of the immune system. So it really makes sense to consider that for those patients in that postoperative status, immunotherapy can actually again reprogram the immune system to treat the remaining microscopic disease that can be there in order to reduce the problem of the relapse. So in this particular setting, we have the Empower 010 that you all mentioned before. Just for you to remember, this is a randomized open-label phase 3 clinical trial that actually recruited patients with a stage 1B to 3A non-small cell lung cancer. PD-1, of course, the analysis was required before entering the trial. Good PS was also required as usual, and patients were randomized after adjuvant chemotherapy for 1 to 4 cycles to either atezolizumab, fixed dose, 1200 milligrams every 3 weeks, or best supportive care. The primary endpoint there was the evaluation of the investigator-assessed disease-free survival in 3 different populations. So from stage 2 to stage 3A with different PD-L1 cutoffs, as you will see now. There were also OS and disease-free survival among patients with really high PD-L1 expression, 50% or higher, as a secondary endpoint. So if we look at the disease-free survival curves, and this is the 5-year survival outcomes that were presented earlier this year or published earlier this year, we have that for all patients with PD-L1 positive status, no matter how high or low that PD-L1 levels were, we see a clear benefit with a 30% reduction in this in the risk of disease relapse. And we also see that for all randomized patients, there was a benefit, although it was not statistically significant. We will see why that can be. So, and well, by the way, this is why FDA approved PD-L1 1 or higher as the cutoff to indicate this treatment and have the reimbursement in most of the countries. But this is not the case of EMA region, as I mentioned before. So what about patients with high PD-L1 expression? Well, we see that the benefit is even higher, and we see a reduction in the risk of relapse, really impressive, with a hazard ratio of 0.48 for patients with or without EGFR or ALK alterations. But even for patients without it, we see a very similar effect. So it is very clear that adjuvant atezolizumab was meeting the endpoint, the primary endpoint in this particular setting. And of course, if we look at the OS, the overall survival, which was the secondary endpoint, we see and more reflected in patients among high PD-L1 expression, again, with or without EGFR or ALK alterations. It doesn't really matter. We see an impressive benefit. For those patients without EGFR and ALK that typically tend to benefit most from immunotherapy in all the different clinical situations, we see that the hazard ratio was 0.44, which is really impressive, and we haven't seen anything like this before. So this is just a summary of how all subgroup analysis, all subgroups were actually benefited from atezolizumab after chemotherapy, after surgery. If we look at the immune or the potential adverse events, of course, we have some grade 3 or 4 adverse events, but this is something that we already know from many other clinical trials with immunotherapy in general. And most importantly, adverse events leading to atezolizumab discontinuation were low. So interestingly, and this has been presented some weeks ago at ASCO this year, what we see is that when we look at those patients with STK11 or KEAP1 mutations, and this is something we know from other many clinical trials, for the metastatic disease biology, these alterations are important because either one of them or both of them typically mean lower benefit to immunotherapy. But this is not the case from atezolizumab in this setting. So we are considering probably a completely different biology of the disease, which we consider early stage. And in fact, no major differences were found among mutations or wild type. There are some other interesting biomarker analysis that have been presented earlier, also in 2023, for example, which is the ctDNA levels and how ctDNA actually disappears or clears or not with the treatment. What we see here is very similar as what we just saw. So all patients, no matter what ctDNA clearance percent or percent at baseline, positive or negative, tend to benefit very similarly. Of course, those patients with higher PD-1 expression levels tend to benefit most. That's something that we already mentioned. But all patients, all subgroups actually benefit, even those patients with ctDNA positive, which means that the treatment is potent enough also to probably destroy that minimal residual disease, which is probably what that ctDNA positive is meaning for this subgroup of patients. And of course, we know that some patients actually cleared ctDNA with the first part of the regimen, so the chemotherapy, the adjuvant chemotherapy. So and some others actually cleared ctDNA only in the second part when receiving immunotherapy. So no matter when those patients actually cleared ctDNA clear meant most benefit for atezolizumab, even though, as I mentioned, all subgroups are benefiting. Patients with ctDNA cleared with chemotherapy, and especially for atezolizumab, as you can see here, up here, tend to have a much better overall survival. Sorry, this is free survival. So we have other relevant clinical trial that has been presented or also earlier, and which is pembrolizumab, the KEYNOTE-091, as opposed to placebo in this adjuvant phase. Again, this is a randomized phase 3 clinical trial, and complete surgical resection was mandatory, good PS, tumor availability for PD-L1 expression, and some interesting stratification factors were included. There was a dual primary endpoint, disease-free survival for the whole population of this study, or disease-free survival only for high PD-L1 expressors. So as you can see here, we see a benefit or a trend of a benefit for the overall population. And very interestingly, which is not the case of the IMpower010 trial that I mentioned before, for high PD-L1 expression levels, we don't see that level of benefit. And in fact, there are no statistically significant differences between placebo or pembrolizumab. So in this case, pembrolizumab seems not to be that beneficial in this adjuvant setting as we just saw for atezolizumab. And if we consider disease-free survival, again, according to the PD-L1 expression levels, so for the intention to treat population here on the left, what we see is a 4-year rate of survival, a little bit more than 52% as compared to 45.7%, which is not that interesting or that impressive. And in fact, again, we don't see that benefit for patients with high PD-L1 expression. And patients who received adjuvant chemotherapy, which was not part of the study in this case, actually seem to have a most interesting benefit from pembrolizumab. But however, we see that the hazard ratio is 0.80, so far from the 0.44 or the 0.70% that we just saw before, according to the different subgroups in the IMpower010. So there is a management proposal for operable early stage non-small cell lung cancer that would be okay. we should review that patient within the multidisciplinary board, and that's something we mentioned before. And we have to evaluate the pulmonary function, the CT plus PET-CT, the histology, EGFR status, probably ALK status is also important, PD-L1 expression levels, as we saw before. We have to correctly stage the mediastinum with EBUS probably, or EOS plus EBUS, or it really depends on the country and the institution. But finally, we have to consider a surgery, and we have to consider after surgery adjuvant treatment, depending on different situations, such as PD-L1 expression, the stage per se, whether that patient is exon 19 or 21 EGFR positive, of course, ALK, as we just mentioned, and depending on that, we can consider adjuvant treatment. And of course, some patients might be good candidates for neoadjuvant therapy, but really, for those patients, we have to decide exactly who, because some patients might not make it to the surgery if they progress during the neoadjuvant therapy. So my take-home messages are, first, early-stage non-small cell lung cancer is an emerging clinical condition with a great potential for curation. We know that those lung cancer screening programs emerging everywhere will probably change completely the epidemiology of lung cancer in our countries, and we will see that probably in a future to come, more than 80% of our patients will be diagnosed really, really early with a stage 1 or 2. Those specifically are patients in which we have to consider neoadjuvant, or more specifically adjuvant treatment, because we know that for neoadjuvant treatment, probably the larger local or locally advanced disease that those patients are, the greatest benefit they can have from the neoadjuvant setting. And for really early stage, probably adjuvant setting with atezolizumab, as we just saw, is probably the standard of care. Multidisciplinary management is key to success. We have different immunotherapy approaches, as we just mentioned, but atezolizumab, more specifically, as we compared to pembrolizumab data, and specifically atezo is a drug that has those 5-year data that are really, really robust. Still, we know that probably STK11 or KEAP1 mutations might not be a barrier for those patients benefiting from adjuvant atezolizumab, and probably all patients, even those with high, minimal residual disease with ctDNA positive, can still benefit very well from the treatment. And even when those patients actually do not clear ctDNA during treatment, they are still obtaining some benefit. Of course, those patients with high PD-L1 expression levels and ctDNA clearance during treatment with atezolizumab are the patients benefit most. Thank you very much.
It was excellent review and talk. Because of time, we'll just only allow 2 questions. And I will start first with the question that for stage 2 and 3A, this is considered the resectable population. And even for 3A, it's still heterogeneity, and it will also depending on the surgeons. And so if you do have the stage 2 and 3A, and this is resectable, and we do have on the other side the neoadjuvant therapy, and putting this together with the confusing data regarding the adjuvant therapy with atezo and pembro and the benefit of this patient, we know that still group of patients with high predictor, high expression, they are benefit, but still some group of patients who did not benefit as well. Putting this together, how we can pick the right choice for the patient, neoadjuvant versus to send the patient for resection.
Right. So I think probably, as you just said, PD-L1 expression is a very important key aspect, biomarker upfront. And what we normally do in my institution is those patients with negative PD-L1 expression or low PD-L1 expression. Those patients typically in the diagnostic sample, which is probably again not estimating necessarily very well what it is in the surgical piece, but that's the information you have upfront, right? So for those patients with low or negative PD-L1 expression levels, what we normally tend to offer that patient, if the multidisciplinary team accords that probably that patient will be a good candidate for resection at some point. That doesn't mean that the patient is operable and resectable from the very beginning, but it could be modified according to a neoadjuvant treatment. Those patients typically are offered chemo-IO neoadjuvant treatment. However, for those patients with PD-L1 high expression levels, what we normally tend to offer those patients, especially for those patients in which we feel might not be good candidates for neoadjuvant treatment because they might not make it to surgery, those patients in which probably surgery is more important because of the symptoms or the breathing status of the patient, whatever situation, those patients are typically treated with surgery first, because we know that later on we are going to be offering very good adjuvant treatment with this impressive data with atezolizumab.
Yes, okay, totally. We do have a question from the attendees that why we do have confusing data between the atezo and pembro regarding the benefit of adjuvant. So how to select?
Well, the truth is that probably, and this is something we've seen also in other settings, right? We as oncologists tend to simplify everything. We are practical people, right? So we tend to think that, okay, all PD-1s, anti-PD-1s, anti-PD-L1 drugs are equal. And, the experience have shown that that's not the case. And we have Durva in the chemoradiation, after the chemoradiation setting, but no other treatments have been approved, right? We have, monotherapy with pembrolizumab or cemiplimab for first-line high expression levels, but nivolumab protocol is not the case. And we have a failure in that clinical trial. So I think the drugs are not exactly the same. Here we are comparing an anti-PD-L1 with an anti-PD-1. Second, I think the design of the clinical trial is probably also different. Having mandatory chemotherapy after surgery in the 010 trial is probably, or might be probably, explaining something too. We know that chemotherapy can again destroy some of the remaining cells that could be there, and as we saw, some patients actually clear DNA only with chemotherapy. So again, chemotherapy probably has a role there, and it's preparing the field for the reactivation to the immune system. That is probably what we see in the Pembro clinical trial when we consider the subgroup of patients that actually receive chemotherapy in the adjuvant setting and then receive pembrolizumab. So different clinical trial design, different populations, probably different drugs. We can have different, even different biomarker testing methods. That's also important. We are not testing PD-L1 with the same drugs, with the same kit, etc., for all clinical trials. That could be very well explaining the differences.
Yes, correct. I would like to apologize to all the colleagues who sending questions, but because of the time, we are running out of time. I would like again to thank you, Prof. Guelbazo, for joining us, and excellent talk and excellent discussion as well. So my pleasure to go to the last part of tonight, which is the Stellite Symposium. I would like first to thank Roche for sponsoring the meeting tonight, and I would like to thank all the colleagues and faculty who are joining us. And it's my pleasure to introduce our chair of the Stellite Symposium, our dearest friend and colleague, Dr. Marwan Al-Hageli. Dr. Marwan Hageli, he's associate professor in King Abdulaziz University in Jeddah, and he is the head director of Oncology Department at IMC. He will chair the Light Symposium tonight. Dr. Marwan, the floor is yours.
Thank you, Dr. Mirvet. Thank you for the great introduction and the kind words. And thank you, everyone, actually, for great input for all the previous presentations and the cases that we discussed earlier. It's my pleasure to be here with you tonight, and I'm going to be chairing the Satellite Symposium. First of all, I want to thank Roche, actually, for sponsoring the event. And it's my pleasure to introduce my colleague and dear friend, Dr. Nafisa Abdel Hafiz. She's a consultant medical oncologist at the National Guard Hospital in Riyadh with the main interest in thoracic oncology. And she will be presenting adjuvant therapy in early non-small cell lung cancer with a focus in ALK-positive disease. The floor is yours, Dr. Nafisa.
Thank you, Dr. Marwan, for the kind introduction. Thank you, Dr. Mirvet, and thank you, Roche, for supporting this education activity. So, Mike, I will present one case, and then it is about early stage non-small cell lung cancer with adjuvant immunotherapy. And then we'll talk about the clinical trials that support my patient approach or treatment. So this patient is a 72-year-old gentleman. He is a retired soldier, quit smoking a few months before presentation. He used to smoke around 20 to 40 cigarettes per day for the last 40 years. He's known to have diabetes, hypertension, benign prostatic hypertrophy, and dyslipidemia. Has no family history of cancer. He's not known to be allergic to any medication. For the first time, he had been seen by a family physician because of chronic cough, stayed for 3 months. The cough was dry and no other respiratory symptoms. The patient denied any GI or CNS symptoms. His clinical examination was essentially normal, as well as his blood test, and his performance was 1. So the first workup that he underwent was a chest X-ray, and the chest X-ray showed round lesion at the peripheral aspect of the right middle lobe, and they recommended CT scan. So the CT scan confirmed that lesion. It was cavitary lesion, suggesting squamous cell carcinoma. And so the patient was a candidate for core biopsy because the CT findings was highly suspicious. Sorry, one slide was missing. So the patient underwent core biopsy, and the core biopsy confirmed adenocarcinoma, TTF1 positive, and NAPSIN as well positive. The patient underwent, after that staging workup, he underwent PET-CT scan. The PET-CT scan, as you can see, it showed the hypermetabolic peripheral right middle lobe mass, as well as hilar lymph nodes, but there was no uptake outside the chest. So the brain MRI was negative for metastatic disease. So the case was discussed at the tumor board, and they advised to go for mediastinoscopy first, and if negative, then they will proceed with lobectomy. Otherwise, patient will be a candidate for systemic treatment. So regarding the result of the core biopsy, the patient was having positive, as I mentioned, adenocarcinoma, TTF1 positive. NGS was negative for any targetable mutation. It was KRAS. The only positive mutation was KRAS, but it was not the 12GC, and the PDL1 was 30%. So the patient underwent bilobar lobectomy. Around 11 lymph nodes were resected. 2 lymph nodes were positive, and the final stage was T2 and T2A and N2 disease. So T2 and N2 M0. So this is like stage 3A. PDL1 was 30%, and the KRAS, as I mentioned before, it was not the targetable one. So the plan was to go for adjuvant treatment. He was started on chemotherapy. He received 4 cycles of carboplatin pemetrexate. This was back in 2021. He completed the adjuvant chemotherapy in 2021, and then he completed, sorry for this mistake, he completed the immunotherapy in November 2021. So he received 4 cycles of chemotherapy. Then that was followed by 16 cycle of atezolizumab, and treatment was completed in November 2021. He tolerated the treatment very well. The only side effect that he developed as a result of immunotherapy was almost grade 1 hypothyroidism, and he is on 50 milligram of thyroxine since then. So he's currently under surveillance. We used to do CT scan every 3 months for the first 2 years, and then every 6 months since then. And he underwent a CT scan this month actually, and there was no evidence of recurrence or metastatic disease. As you can see, this is his latest CT scan. He was doing great. His performance was excellent. No complaint. He's still on thyroxine 50 since we used to regular TSH and T4, and his blood tests were within the normal ranges with this dose. The next follow-up will be in December of this year, and he will have new CT scan before the appointment. So the patient, if we can talk about his overall survival, patient was diagnosed in 2020, April, but he had been seen for the first time by medical oncology and investigated for cancer in August 2020, underwent surgery, and then completed his adjuvant treatment in November 2021. He completed 1 year of atezolizumab in November 2021, and now we're talking in 2025. He's almost 4 years post completion of adjuvant immunotherapy, and he's doing well, and there is no evidence of local recurrence or distant metastasis. So why did we choose atezolizumab, and what is the background for this treatment? So as it had been mentioned many times during this meeting, this was according to the Empower 010, and we know that the adjuvant, as Prof. Gilbazi mentioned, very clear, the adjuvant chemotherapy did not improve the overall survival that much in patients with early stage non-small cell lung cancer. If we look at the overall survival, it was only 5 years overall survival, it was only 4 to 5%. There was improvement in disease-free survival, but it was not that impressive. And this, unfortunately, continued for years and years till we had the emerging of novel therapy. Mainly, I'm talking about osimertinib, which was the first one, and then followed by alectinib recently. So osimertinib for 3 years improves the overall survival significantly for patients with EGFR mutation. So that was very good, but unfortunately, the number of patients with such mutation, they are not the majority of the patients. So still we have a good number of patients who are left with unmet need, and still the disease used to recur very fast, even they are having early stage non-small cell lung cancer. So the Empower 01 evaluated the efficacy and safety of atezolizumab after resection of early stage non-small cell lung cancer and after chemotherapy. So the main thing that I need to talk about here is that the randomized patient randomized to atezolizumab 1200 milligram every 3 weeks, total of 16 cycles versus best supportive care. So this is not a placebo trial. And in Empower 010, they mandate the patient to have chemotherapy. It's platinum-based chemotherapy. It's not like in the pembrolizumab, so a group patient did not receive adjuvant chemotherapy. So here, all patients, 100% of the patients received adjuvant chemotherapy, platinum-based, and cisplatin. It was cisplatin mainly, with pemetrexed or gemcitabine or docetaxel, total of 4 cycles. They look at around 1,200 patients. All of them underwent complete resection, R0 resection with excellent performance status. They include patients from stage 1B up to 3A. So as I mentioned, stratification was atezo versus best supportive care. Atezo up to 1 year, randomization was 1-to-1, and they randomized around 1,000 patients. So patients were stratified by gender and stage, histology, and PD-L1 level. And the primary endpoint was disease-free survival. And they look at this hierarchically. It means that they look smaller and then they widen the umbrella. So, and we'll talk about this later. So the secondary endpoint was overall survival in intention population, and they look at patients with PD-L1 more than 50%. And they look also at DFS at 3 and 5 years. So how do they do the analysis? The initial DFS, they look at patients with PD-L1 more than 1% in stage 2 and 3A population. And if that one is positive, then they go down and include all the comers, regardless of the PD-L1 level. And if that one positive, they go to intention to treat population, i.e. they include patients with stage 1B. So looking at the 3 groups, so you can see the baseline characteristics are well balanced and in the 3 groups. So what about DFS in patients with PD-L1 more than 1%? So if you look at that, you can see the median DFS was not reached at the time of the initial analysis. So as the hazard ratio was really significant, it was 0.66, a significant p-value. You can see very clear separation of the curve, and the 2 curves continue to separate after that. So the primary endpoint was met with a significant hazard ratio for patients with stage 2 and 3A and positive PD-L1. So looking at the subgroup analysis, you can see all patients actually benefited from the addition of atezolizumab regarding of the gender, race, performance status, and the histology. And even patients with EGFR and ALK mutation, they had benefit from atezolizumab in the adjuvant setting. Looking at N1 and N2, you can see a patient from stage 3A to 2B, all the stages benefit from the addition of atezo. So what about, so they went down to include all comers, all patients, regardless of the PD-L1 positivity. So there was some sort of benefit, and that the hazard ratio was 0.79, but that was not very statistically significant. But still, there was a benefit from giving atezo in this group of patients. So looking at the patient with different levels of PD-L1, so the obviously patient with PD-L1 negative or less than 1%, there was no benefit in that group. Patient with PD-L1 more than 50% benefited the most, followed by the patient with any positive PD-L1. So what about patient with the all-comer, the intention to treat population? So the significant boundary was not crossed in this interim analysis. So it was negative. As I mentioned, those groups did not benefit from the addition of atezo. So looking at the intention to treat population, you can see that the hazard ratio was not, it was 0.8 only. So looking at overall survival in the initial analysis, you can see the patient with PD-L1 more than 1%, you can see the separation of the curve even after the continuation of the discontinuation of atezolizumab in all patients. There was no significant benefit in the overall survival. So the safety profile, the most important, there were no new safety signals, so nothing new. It is the same like when atezolizumab used for different indication, and when it was used with when it was combined to chemotherapy. You can see there was some sort of grade 3 and 4, around 20% developed grade 3 to 4 adverse event. 18% had need to discontinue the treatment, and around 20% of the patient, 28% required dose interruption and modification. What about immune-related adverse event? It was mainly grade 1 and 2. Patient who developed grade 3 and 4 was almost less than 2%. So the Empower 010 is a new standard of care for the patient with stage 2 and 3A non-small cell lung cancer after complete resection following platinum-based chemotherapy with significant improvement in DFS with a hazard ratio of 0.66. Still, the patient with stage 2 and 3 they get some benefit, but that was not statistical without PD-L1 positivity. This was not statistically significant. So the safety and the medication was safe, and there was no new safety signals, as I mentioned before. So what about overall survival interim analysis of phase 3 atezolizumab? So this is a trial again. I think we heard enough about it. Now I'm gonna go to the latest analysis of the trial. So just to remind you that it was positive for patients with PD-L1 more than 1%, significantly positive for the patient with PD-L1 more than 50%. And when they look at the patient with targetable mutation, specifically EGFR and ALK, still those patients did very well with the addition of atezolizumab after R0 resection. So like 13 months later at 45 months, you can see here, this is the initial data at 32 months. You can see the DFS in stage 2 and stage 2 all patient and stage 1B to 3A intention to treat population. And as mentioned before, it was negative in this group. So the overall survival was, there was trend toward improvement in overall survival in patients with positive PD-L1, but there was no benefit, the clear overall survival benefit in patients with without PD-L1 positivity. So what happened after that in overall regarding overall survival at the second analysis in 46 months, you can see that there was the curve still continued to separate. At the time of analysis, the median overall survival was not reached and the hazard ratio was still significant. So what about overall survival for patient with without stage 2 and 3A without PD-L1 positivity or regardless of PD-L1? And what about patient overall survival in intention to treat population? You can see that it was not significant. The hazard ratio was 0.95 in both groups. So what about overall subgroup analysis and overall survival in patients with positive PD-L1? So any positive PD-L1, more than 1%. And just I need to remind you, with our patient, his PD-L1 was 30%. So he had good positivity for PD-L1. So, and he was a smoker and having N2 disease. So he's one of the patients who had good response according to the subgroup analysis. So if you look here at in terms of DFS and overall survival, if you look here at the subgroup analysis, you can see again, smoker and never smoked all had good response to and improved overall survival when atezolizumab was added after chemotherapy. Stage 2A, 2B, and 3A, all of them had the same benefit, and the benefit was regardless of the positivity N1 or N2, positivity of the lymph node, and regardless of the kind of surgery. So I don't know why, but I noticed our patient underwent by lobectomy, and here if you can see, those are the patients who had the most benefit or benefited the most, but maybe because the number of the patient is small, like only 24 patients, so we cannot build on that. But just I noticed this during my reading of the trial. So regardless of the chemotherapy, obviously patients with gemcitabine, they did not do that well. Again, the number of patients was not the higher. And I think this is not the standard. We're not using gemcitabine in the adjuvant setting very much. So looking at patients with EGFR and ALK mutation, you can see, as we mentioned before, they had benefit once the PD-L1 is more than 1%. So this is overall survival by biomarker. This is already I mentioned that when the EGFR and ALK positive, the subgroup analysis showed that the positivity of PD-L1 is a good biomarker for the benefit from atezolizumab, even with patient with targetable mutation. And we can see that the higher the PD-L1, the best is the response. What about PD-L1 more than 50%? This was there was substantial benefit in the overall survival. The hazard ratio was really striking. It was 0.42, so almost 60% reduction in the death rate if we added atezolizumab after chemotherapy for stage 2 and 3A after complete resection, and if their PD-L1 is more than 50%. So again, this is the safety profile, no new safety signals. Still we're talking about the same toxicity profile. It was mainly skin toxicity, dermatitis, and hepatitis, and pneumonitis. All the grades were mainly grade 1 and 2. The number of grade 3 and 4 was very small. Less than 1.5%. So overall survival, there was improvement in overall survival for patient with non-small cell lung cancer, regardless of the histology, stage 2 and 3A population after complete resection of the tumor, R0 resection, followed there was overall survival benefit when atezolizumab followed chemotherapy for those patients. Patient with PD-L1 more than 50%, this population benefited the most. There was significant improvement in overall survival. And the last interim analysis showed like 6% reduction in the death rate with a hazard ratio of 0.43. Again, the medication was safe, no new safety signals. Most of the side effects were only grade 1 and 2. So the data support the usage of the addition of atezolizumab after chemotherapy in stage 2 and 3 non-small cell lung cancer after complete resection and after the standard chemotherapy. Thank you.
Thank you, Dr. Nafisa. Thank you so much for this excellent presentation. And again,
thank you, Dr. Marwan.
Yeah, so maybe I will cover some of the questions that Dr. Mervat did not get into. But really amazing talk. And I think maybe the discussion will be about radiotherapy, where you can implement that and whether you can combine it if you're willing to.
Yeah, I think Dr. Marwan, we have some data about giving radiation therapy at the early stage, and I think the data was not in favor of giving them chemotherapy, and it was associated with high toxicity. So maybe with the stage 3B, yes, we can go for concurrent chemo radiation followed by immunotherapy. But for the stage 2 and 3A, the patient can go for neoadjuvant or adjuvant treatment, immunotherapy combined with chemotherapy. I think that will be preferable.
I have a question. Okay.
Go ahead, Dr. Abdel Nasser.
Okay, now when it comes to adjuvant alectinib in ALK or Tagrisso and EGFR, if you want to go and give immunotherapy plus chemotherapy to those subset of patients, do you think that the proper way, or you have to go to, as standard right now, alectinib in adjuvant setting for those patients? My understanding that in metastatic setting, even if you have PD-L1 expression is there or high, you go with the targetable alteration, like you go with alectinib in metastatic, and maybe after progression you may consider whether we get too many lines. Right now we don't have to go to chemo or immunotherapy. What's your take on this scenario?
Yeah, thank you for this excellent question. We don't have, Dr. Abdullah, a head-to-head comparison between the two. We don't have a comparison between when we give adjuvant immunotherapy and adjuvant targeted therapy. We don't have head-to-head comparison. But if we are extrapolating from the metastatic setting, the priority will go for targetable treatment. We should have go for targetable treatment, and we go for immunotherapy maybe in the second line. But upfront, we should start with the targetable mutation and give the target. Again, for the adjuvant setting, I think definitely I would try to avoid. And the idea beyond this is the toxicity which had been observed on those patients when the patient with targetable mutation when they receive chemotherapy. This is one of the things that we should try to avoid immunotherapy as much as we can. So it's the same in the adjuvant setting. We try to go with a targetable mutation first, and if the patient develop disease progression, then you go to do you have to have another biopsy and you treat accordingly. The second thing that PD-L1 is not the best biomarker. So maybe the patient will not benefit because there is another mutation there are another clone which are not will not be inhibited by immunotherapy. So you will be having that clone is active. So if the EGFR or ALK, so you will be having a functioning active clone that might cause cell proliferation and progression of the disease. So I think giving the target for the patient with targetable mutation will be the best approach. I don't know if anyone else having different input on that.
You want to comment, Dr. Mervet?
I think Dr. Nafisa covered, thank you, Dr. Marwan. I think Dr. Nafisa covered very well the subject, and I will concur what she said. I will just only add to the point that you raised regarding the radiotherapy, which is really good because we missed this part on our talk. The main issue is that radiotherapy now in lung, because we do have the EPIS and the mediastinoscopy before going for such surgery, and so we are recognizing. So the radiotherapy it's supposed to be for positive margins or patient with N2. And because we are now going for the new adjuvant therapy for stage 3B or concomitant chemoradiio in Pacific for stage 3C, this is why the radiotherapy became on the upfront for the stage 3C, but in the postoperative only for positive margin or R1 resection. And so we have to, this is a small percentage of patients. I think your question is very valuable. So if we do have patient with N2 or positive margin, what is the space for radiotherapy for this patient? The sequence for this, we need to go for 4 cycles of chemotherapy, giving the patient the radiation, and then we may go for immune therapy. And this is anticipation more than because it was not addressed in the studies, but just only if we do have such patients.
Excellent. Excellent, Dr. Mervet. Yeah, I think that's why the change happened just before the diagnosis and before we going even for surgery. What just like I have a patient who she had a very small lesion and we did the surgery and she ended up actually having an N2 disease, which was negative everything.
Yes, it happened. It happened.
It happens.
Yeah.
I think that's just one of the unfortunate scenario, I would call it. Although, but anyway, sometimes it can happen. Okay. Yeah, I'm just so I think we talked about the side effects and the follow-up and everything in details actually over the several talks that we had. But really, if anyone has any question or comment, I'd love to take for now. Since I think now we have 3 immunotherapy between neoadjuvant and adjuvant treatment that we can use. I think it just like somewhere or another, every patient has to get some immunotherapy.
Yes,
is there a patient that you would
at some point?
At some point, is there like a patient that you think of that they should not be receiving any immunotherapy, especially with the PDL result? Do you have any thought about that?
Well, the immune therapy, by the way, you're absolutely right. The majority of the patient will go for it. But however, the patient with autoimmune disease or the patient who have, because I do have one patient with HCC, and this patient, she was having psoriasis. The patient, once she received the treatment, she has a flaring, and this was learning point. And also, I do have another patient with a scleroderma. She has a durable response with the immune therapy, but she was having a very bad disease regarding the scleroderma. So the percentage of patient who is not, we are not able to give, still the patient with autoimmune disease or patient with a transplant, still we don't know exactly what to do for them. But if you are referring that in which staging we need to not to give, I think it's the individualize it. Now it's like one of the tools. We are looking at, and of course, the patient with the driver mutations, they are not responding well to immune therapy. And between now and then, we found that they are taking the from the second line to upfront therapy. Still, of course, the EGFR and the ALK, the preferred one is the targetable. However, the immune therapy for the KRAS and PRF is still as an upfront immune therapy, and then we may consider. And even on the last ASCO, there was a Pembro plus Adrecept for the patient with G12C. So it seemed that between now and then, they will take their way as an upfront as well.
I have one of my patient, like stage 3A. He's post-liver transplant, and we're not able to give him immunotherapy. We just give like 4 cycles of chemotherapy. He had complete pathological response. His PDL1 was less than 1%. So I was just happy when I saw the PDL1. So nothing to regret. Or he might require immunotherapy at some point, as Dr. Marwan mentioned, if he's not, if he had disease recurrence or progression. But till now, he's doing well on observation after 4 cycles of chemotherapy with complete pathological response.
Great. Dr. Nafisa, just excuse my ignorance. Why pemetrexed was not part of the regimen that you used?
I was really surprised.
Okay, so it's not only me.
No, it's not only you, but it was. They did not. I was surprised why gemcitabine was the main. So they mentioned gemcitabine, vinorelbine, taxane, and the last they mentioned pemetrexed. It was used, but I think it was not the major player. They just use it like the rest. So and which is not the standard of care. This is the standard of care, ciscarbo plus pemetrexed. This is the commonest one. But still, people are using vinorelbine, still using taxane, but it was really surprising when they put gemcitabine like equivalent to pemetrexed.
Yeah, because I was wondering why. But if anyone has any comment about the pemetrexed, it's just gonna be great.
Maybe they give a chance or window to enroll more patients. This was like a multi-center trial. It's like sometimes it's different from center to center. Patient with poor performance, maybe, but they mentioned patient were having performance 0 to 1. But maybe they considered patient with renal impairment. I think they just look at certain toxicity and they're trying to tailor the add-on chemo to platinum background.
The preferred regimen for the adeno is the pemetrexed.
Yes.
Yeah, and the second one after pemetrexed is a tolerability, and it's equivalent to venrabine. And for the squamous, the preferred regimen is gem. However, the gemcitabine is not going well with the immune therapy, and this is with multiple trials. So if you are planning to go for immune therapy for this patient as a subsequent or as a combination, gemcitabine is not a good one. So you may go for taxanes for this patient. This is why when we are seeing, this is again, this based on the subgroup analysis, we found that on the PIMPRO study, also in the NIVO and the NATIZO, that gemcitabine is not a good companion. And so this is why for the adjuvant, the the Alimta or pemetrexate is the preferred, and the second best, but because of the toxicity, the Vernabine should be in a good performance young population more than, and the third it will be the taxanes as well.
Even in the subgroup analysis, if you noticed, the gemcitabine people, they did not do the best. They were not the best patients.
Yeah.
So that the response was better with pemetrexate and taxane, not with gemcitabine.
Yeah, correct. Yeah, it was very pronounced on, and it's not only on this one. It's in multiple trials as well. So they may consider it's just a finding. It's not a good companion.
Yeah.
So, but there is no like red flag or signals or black box warning about pemetrexate and atezo. That
no, nothing. I think this is only they just try to widen the participation and include patient, even if they have toxicity or contraindication for any medication, they have choices.
All right. I think well, just reaching toward the end of our talk and our assigned time. But thank you, Dr. Nafisa, actually, for the great presentation. And thank everyone, also Dr. Mervat, for her invitation and organizing this meeting. But I'll give the microphone to you, Dr. Mervat.
Thank you again, Dr. Marwan.